Okay, in our video series of rheumatology lectures, in this video, we are going to talk about antiphospholipid syndrome. We are going to talk about its presentation, its causes, its diagnosis, and management in detail. First of all, we have a case here. A 28-year-old lady comes to your clinic and she is distressed, she is depressed, she is crying, and she tells you, the doctor, I have had 3 miscarriages. What is wrong with me? I have lost 3 pregnancies, and every pregnancy was lost around 10 to 12th week. My gynecologist said that everything was going fine and the cause could not be found, that why the pregnancies were lost. When you take the history from the patient, you find out that 2 years back the patient also had an episode of leg swelling due to deep vein thrombosis. Now, this is the point that triggers you to think about antiphospholipid syndrome. Recurrent episodes of miscarriages with a thrombotic episode like DVT is a classical textbook presentation of antiphospholipid syndrome. What is antiphospholipid syndrome? How do you diagnose it? Today we are going to talk about that. Now, what is antiphospholipid syndrome? Antiphospholipid syndrome is an autoimmune disorder where the immune system is attacking its own body and causing all the problems, characterized by recurrent arterial or venous thrombosis, where the clots are being formed in the arteries, in the veins, or the pregnancy complications where the pregnancies are lost. In the presence of antiphospholipid antibodies are formed and they cause all these clot formation and thrombosis and pregnancy complications. Now, it can be either primary or secondary. In primary cases, the cause is idiopathic. We do not know the cause. Why is this happening? Why the immune system is getting activated and why is it attacking its own body and forming the clots all around? In some cases, it has been found to be related to the genetics, where HLA-DR7, if present in a person, predisposes the person to develop antiphospholipid syndrome. In the secondary causes, there is another disease that is causing antiphospholipid syndrome. In the secondary causes, systemic lupus erythematosus (SLE) is the most common one and is the most important one that you will be tested upon in the exams. In the secondary causes, SLE is the most important one where the antibodies are formed and those antibodies damage the body and those antibodies also cause antiphospholipid syndrome. Must remember this point. I have a whole video on SLE. You can check out that video in my rheumatology lecture series. Certain neoplasms are also associated with antiphospholipid syndrome. HIV, Hep A, B, C can also cause antiphospholipid syndrome. But in the secondary causes, must remember SLE. Now, why does antiphospholipid syndrome occurs? Autoantibodies are formed. The antibodies that attack the own body, they are formed either due to genetics or they can occur in SLE where the antibodies are being formed. And those antibodies attack the membrane phospholipids like cardiolipin. Cardiolipin is a membrane phospholipid that is present in the inner mitochondrial membrane. And that is a normal part of the body. But antibodies are formed against this cardiolipin and they result in antiphospholipid syndrome. Beta-2 glycoproteins are the plasma proteins that are involved in the coagulation process. Now, when antibodies are formed against these beta-2 glycoproteins, the coagulation process is accelerated and they result in clot formation around the body. Therefore, a prothrombotic state develops where there is increased clot production in the body. Therefore, you see arterial and venous thrombosis in these patients. Now, arterial and venous thrombosis, deep vein thrombosis, this makes sense. But now you would be thinking that why does pregnancy complication occur in these patients? Why are pregnancies lost? Pregnancies are lost in these patients because the placenta with which the fetus is attached to the maternal body, now that placenta contains a lot of vessels and clots are formed and they block those placental vessels. Therefore, the placenta cannot receive nutrition and blood from the mother. Therefore, the fetus dies. And a normal pregnancy is lost in these cases with no structural abnormalities in the fetus. Everything is going fine and all of a sudden the pregnancy is lost. This is antiphospholipid syndrome where antibodies are formed against cardiolipin and beta-2 glycoprotein that results in a prothrombotic state. With that, there are antibodies that activate the endothelium of the vessel and they also activate the platelets that result in aggregation of the platelets, and that aggregation of the platelets also results in clot formation. So that is another mechanism where the antibodies are causing platelet aggregation. Now, coming to the clinical presentation of antiphospholipid syndrome, when you understand the pathophysiology, the clinical presentation makes sense. There will be clot formation within the veins, there will be clot formation within the arteries, there will be clot formation within the placental vessels, therefore there will be effects on the pregnancy. Now, in the veins, it would be causing deep vein thrombosis. This will be a very common scenario that young patients will have unprovoked DVTs and they will be investigated for antiphospholipid syndrome in the ward. That is something that should trigger you to think about antiphospholipid syndrome. Pulmonary embolism, where there is clot formation and that is blocking the pulmonary vessel. Livedo reticularis. In the livedo reticularis, what happens is that clots are formed within the capillaries, and when the capillaries are blocked in the skin, the venules get dilated. When the venules are dilated, those venules can be seen on the skin. This is a picture showing dilated venules, and this occurs due to blockage of the capillaries in the skin by the blood clots. If arterial thrombosis occur, it would result in strokes, it would result in transient ischemic attack, it would result in myocardial infarction, ischemia, and gangrene of the vessel, acute limb ischemia. If pregnancy is affected, then it would result in recurrent miscarriages because the placental vessels are blocked. So it is the prothrombotic state that is causing formation of small clots, and those small clots can affect veins, arteries, and it can affect the placental vessels. If the capillaries are affected, it would result in splinter hemorrhages. Splinter hemorrhages are small bleeds that you will see in the nail beds. Now, coming to the diagnosis of antiphospholipid syndrome. For diagnosis of antiphospholipid syndrome, there is a criteria called as revised Sydney criteria. In that criteria, you have to have one clinical evidence of antiphospholipid syndrome and one lab evidence of antiphospholipid syndrome. If you have one clinical and one lab evidence, then you can surely say that this patient has antiphospholipid syndrome. Now, what are the clinical evidences and what are the lab evidences that you can gather? Now we are going to talk about that. In the clinical evidences, you can have one or more episodes of thrombosis. If a patient had an episode of deep vein thrombosis, or if a patient had an episode of stroke, or if the patient had an episode of MI, that counts as an episode of thrombosis. And you do not know the cause, that why did this thing happen, that was unprovoked, you do not know the reason of that, but that young patient had a deep vein thrombosis, you do not know the cause, that counts in the clinical criteria. Or if there is any complication in the pregnancy. Now, what counts as a complication of pregnancy? If there are 3 or more consecutive unexplained first trimester miscarriages, less than 10 weeks, there are 3 or more miscarriages and they are consecutive and they are unexplained, where there is no morphological abnormality in the fetus, but still the pregnancies are lost, that counts as a clinical criteria in antiphospholipid syndrome. If there is any structural malformation in fetus, that does not count as pregnancy loss, because that structural abnormality is causing the pregnancy loss. In the criteria for antiphospholipid syndrome, it should be unexplained pregnancy miscarriage, and there should be 3 or more consecutive miscarriages if it is less than 10 weeks. 1 or more fetal losses if it is greater than 10 weeks. So if more than 10 weeks have passed, it is the chances of pregnancy losses are less after 10 weeks. Now, if even one fetus is lost after 10 weeks, that counts as a clinical criteria. If there is a preterm birth less than 34 weeks, even if the pregnancy reached 34 weeks and the pregnancy is lost, that is preterm birth, that counts as a clinical criteria in pregnancy. So if a patient has any one of these, you can say one clinical criteria is fulfilled. Now, coming to the lab criteria. In the lab criteria, what you do is that you test certain antibodies, and these tests should be persistent for greater than or equal to 12 weeks. What it means is that you perform those tests today, and after 12 weeks, you again perform those tests. The tests should be positive at both incidents. When today you perform the test, the antibodies are positive. After 12 weeks, you perform the tests again and the tests are positive. Persistence for 12 weeks. 2 tests with a minimum gap of 12 weeks are needed to fulfill the lab criteria. Now, lupus anticoagulant is a very important antibody that you will be tested upon in the exams, and there are some important points that you need to remember. Remember, due to this lupus anticoagulant test, you see a prolonged PTT in patients of antiphospholipid syndrome. Now, this doesn't make any sense, because since antiphospholipid syndrome is a prothrombotic state, so in the prothrombotic state, the PTT should not be prolonged, because a prolonged PTT shows that there is increased tendency for bleeding in a patient. If PTT is prolonged, partial thromboplastin time is prolonged, it means that the patient has increased chances of bleeding. But antiphospholipid syndrome is a condition where there is increased clot formation. So this doesn't make any sense. because this prolonged PTT in antiphospholipid syndrome is a false prolongation. This PTT prolongation is false positive. This false positive results occur because this clotting profile test that we do in our laboratories, it is basically uses some phospholipids. The reagents that we use to test the clotting profile PT and APTT for the patient, these use certain reagents, and those reagents contain phospholipids. Now, when you have a blood of antiphospholipid syndrome patient, those patients have antiphospholipid antibodies in their blood. Now, in these patients, when you add this reagent, these antiphospholipid antibodies would bind these phospholipids and would not let them activate the clotting factors. Therefore, you would see a prolonged APTT in these patients, which is actually a false positive test. Due to these antiphospholipid antibodies that are binding the phospholipids in the reagent, therefore the reagent cannot act on the blood and cannot activate the clotting factors. Therefore, you see a prolonged APTT, which is false positive. This is very, very high yield that you need to memorize, that you need to understand. Now, just like PTT, which is a clotting profile test, dilute Russell-Viper venom time test is also a clotting test, and this clotting test also uses phospholipids. Now, when a patient has antiphospholipid antibodies, these antiphospholipid antibodies would bind these phospholipids and would affect the results. The results will show prolonged Russell-Viper venom time, which is false just like a prolonged PTT. Now, when you get a prolonged PTT, you really want to find out that whether it is false positive prolongation due to antiphospholipid syndrome, or is it actual prolongation due to actual deficiencies of the factors, due to the actual deficiency of the clotting factors. To confirm that whether this is a false positive or it is actually positive, you do a mixing study. In mixing study, what you do is that you take a plasma of a person that has normal clotting factors. A normal plasma is taken and it is mixed with the sample which has prolonged PTT. In this sample, if you mix this plasma of a normal person, this normal plasma contains the clotting factors. And if you mix it with this prolonged PTT sample, the sample of an antiphospholipid patient that had a prolonged PTT, if you mix this normal plasma and if it corrects, if the PTT normalizes, it means that there was actual deficiency of the clotting factor and it was not false. But in antiphospholipid patients, what happens is that when you do mixing study, when you mix a normal plasma, the PTT still remains prolonged because it is not the deficiency of clotting factors causing it. It's the antibodies that are binding to the phospholipids of the reagents and causing the prolongation. Therefore, mixing study is done to confirm the false prolongation. Now, when you have the prolonged PTT and you do the mixing study, and in the mixing study you see that the PTT is still prolonged, it means that it is not the deficiency of the clotting factors, it's the antibodies against the phospholipids that are affecting the result. Now, in the third step, what you do is that you actually add the phospholipids from outside. The phospholipids of the reagent that got deficient due to the antibodies that were bound to it, you actually add more phospholipids. And when you add more phospholipids, the PT results, the APTT results would normalize because the extra phospholipids would be there and now the antibodies are no more there and the results will be normalized. The prolongation of PTT will return back to the normal levels. So this makes sense because of the lupus anticoagulant, there will be falsely elevated PTT. This will be our commonly tested point in your exam, that why is the prolonged PTT in lupus anticoagulant, or why is the PTT prolonged in antiphospholipid syndrome. Now, with the lupus anticoagulant, there are other antibodies that you can also detect in antiphospholipid syndrome patients. Those include anticardiolipin antibody, IgM, IgG. These are antibodies against cardiolipin, cell membrane phospholipids. Anti-beta-2 glycoprotein antibodies can also be detected. So if any one of these antibodies is positive, you can say that the lab criteria is fulfilled. So you need one lab criteria and one clinical criteria. If one lab criteria and one clinical criteria is fulfilled, in that case, you can say the patient has antiphospholipid syndrome. Now, another important point, another false positive result other than APTT that you will see in these patients is the syphilis test. The syphilis screening test VDRL and RPR will be falsely positive, and these are also positive due to these antibodies. These antiphospholipid antibodies react with the reagents that are used in a VDRL and RPR, and they cause falsely positive VDRL and RPR test. Now, how would you know that whether this is real syphilis or this is due to antiphospholipid syndrome? Now you have to go one step ahead. You have to perform FDA ABS test, a confirmatory test for syphilis in these patients, and FDA ABS test would be negative, but the VDRL RPR would be falsely positive. I have a full video on syphilis. You can check out that video in my infectious disease section. Now, coming to the treatment of antiphospholipid syndrome. In antiphospholipid syndrome, these patients are having a hypercoagulable thrombotic state. In that situation, you have to give anticoagulants to these patients. Now, in the primary thromboprophylaxis, the patient will have no history of thrombosis, but the patient will have history of obstetric antiphospholipid syndrome. The patient will have recurrent miscarriages, but the patient does not actually fulfill the Crivice-Sidney criteria. The patient does not fulfill both the lab and clinical criteria, but one of them is positive. Either the lab criteria is positive or the clinical criteria is positive. In such situation, you give low dose aspirin 75 to 100 milligram daily to these patients and see the response, and most likely these patients will get better and the obstetric complications would go away. Now, in these patients there is no history of thrombosis, but we are giving aspirin to prevent any clot formation in the future. Therefore, this is called as primary thromboprophylaxis because there is no history. The clots have yet not happened, but the patient is at risk of developing the clots. In secondary thromboprophylaxis, the patient has a history of clot formation, patient had a DVT, patient had a stroke or an MI. In such situation, the first line is warfarin. You have to start warfarin 2 to 10 milligram per orally OD, and you target an INR of 2 to 3. Now, before starting warfarin, you give a heparin bridge. For first 7 to 8 days to achieve an INR of around 2 to 3, you give enoxaparin, a low molecular weight heparin, 1 milligram per kg subcut 2 times a day. And when you reach the INR of around 2 to 3, then you stop enoxaparin and you start warfarin. Now, why are we giving bridging therapy? Because warfarin causes a procoagulant state in the first few days. Therefore, you achieve the INR through heparin for the first few days and then you start warfarin. If there is any contraindication to warfarin, you can give molecular weight heparin, but the problem with heparin is that it is present in injections, and warfarin is easy to take because it is in the form of tablets. Now, if there is any contraindication to warfarin, in such situation, you can give low molecular weight heparin and enoxaparin to these patients. But the problem with enoxaparin and heparins is that these are to be given by injection, and warfarin is available in the form of tablets, so the patient has more compliance with tablets rather than having injections every day. So you give enoxaparin if the patient is having any contraindication to warfarin, or you can give direct oral anticoagulant drugs. But remember, direct oral anticoagulant drugs are not recommended if the patient has a history of arterial thrombosis. Now, if secondary thromboprophylaxis is needed, if there is history of clots and antiphospholipid in pregnancy, in such situation warfarin cannot be given because warfarin is teratogenic. In such situation, you give a combination of low dose aspirin with heparin, low molecular weight or unfractionated heparin. General measures that you have to do in these patients is that you avoid estrogen containing medications because these patients have risk of clot formation. You ask them to stop smoking because smoking is a trigger for clot formation. Now, when you have started anticoagulants in these patients, it's very important that you tell to these patients that you have to follow up with your doctor and keep checking your INR so that it remains in the normal limits. And if in any case they forget to take the tablet during the day, they can take it as soon as possible, but they cannot take it the next day. They cannot take double dose the next day if they forget the previous day dose. Therefore, it is important to counsel these patients regarding the dosage. With that, you tell these patients if they get severe headache, they should immediately come to the hospital because there is a chance that they are at increased risk of bleeding. They should not participate in the sports that makes them prone to getting injuries that would result in bleeding, because their bleeding process is not like normal people where the bleeding would stop after some time. In these patients, the bleeding would go on for a longer period of time. And it is important to tell to these patients that the follow-up is very, very important. Now coming to catastrophic antiphospholipid syndrome, and in catastrophic antiphospholipid syndrome, as its name implies, it is an emergency in which a diffuse systemic thrombosis starts to occur. Acute systemic small vessel thrombosis begin, resulting in clot formation in each and every organ, resulting in multi-organ failure. And it is an emergency with 50% mortality rate even with the treatment. It's a deadly combination of antiphospholipid syndrome. The treatment is giving heparin immediately, high dose glucocorticoids are given, plasma exchange to remove the antibodies from the plasma is done, IVIG antibodies that bind to the antibodies, antiphospholipid antibodies, IVIG is given, and mortality is 50% even with the treatment in catastrophic antiphospholipid syndrome. Before going to the summary, if you liked my video, please click on the subscribe button and make sure to check out my other videos on SLE and rheumatology lectures, neurology lectures, emergency medicine lectures, ECG lectures. The link of those videos is given in the description below. We talked about what is antiphospholipid syndrome, SLE being the important secondary cause. Anticardiolipin and anti-beta 2 glycoprotein antibodies are formed. Venous thrombosis occur, arterial thrombosis occurs, pregnancy combination occurs in these patients. And in the lab criteria, lupus anticoagulant would cause a falsely prolonged PTT. Anticardiolipin antibodies, anti-beta 2 glycoprotein antibodies, one lab and one clinical criteria needs to be fulfilled. False positive VDRL and RPR syphilis tests will be there. In primary thromboprophylaxis, you have to give aspirin. In secondary thromboprophylaxis, where there is a history of clot formation, you have to start warfarin. If there is contraindication to warfarin, give enoxaparin. In pregnancy, give low molecular weight heparin. Avoid smoking cessation, counsel the patient regarding anticoagulant intake, and at the end we talked about catastrophic antiphospholipid syndrome. If you liked my video, please click on the subscribe button and make sure to check out my other lectures on my YouTube channel. You can also follow me on Instagram, and you can support this channel on Buy Me a Coffee. Thank you very much.